student social worker on placement. Wonderful. Jewish Care Youth Services.
Psychologist. Yeah, wow. It's really good.
Anna from Jarkenjung Lands in New South Wales, teacher. Mental health educational worker from Perth. Oh, right across the country. Wonderful. Queensland, Maryborough, Queensland, Mel, social worker, disability liaison worker, Swan Hill. 91. Wow, we're going up.
Oh, yeah, right.
Right, well, let's get underway. Welcome to all. 93 and building to this Mental Health Foundation Australia educational webinar. Professor Malcolm Hopwood will be sharing his insights into innovations in the 2020 RANZCP clinical what's the title? Clinical
Mood disorder guidelines.
Mood disorder guidelines. So thank you. This will be a 20-minute webinar presentation followed by 15 minutes of Q&A. If you have any questions in advance for the speaker, please feel free to mention them in the checkout. So use the Q&A function, is probably best for that. And if you have any other questions of the Mental Health Foundation, please don't hesitate to contact us on 1300 643 287. Professor Malcolm Hopwood is currently the Ramsay Healthcare Professor of Psychiatry, University of Melbourne, based at the Albert Road Clinic. At the Albert Road Clinic, he provides inpatient care within the Professorial Psychiatry Unit, as well as outpatient consultations focused on second psychiatric opinions. Malcolm has a long track record of involvement in psychiatric research. His research areas of interest include clinical aspects of mood and anxiety disorders, psychopharmacology, and psychiatric aspects of acquired brain injury. He also leads the undergraduate and registrar training schemes at the Albert Road Clinic. Malcolm was president of the Royal Australian New Zealand College of Psychiatrists from 2015 to 2017. He's now president of the Asian Federation of Psychiatric Associations, and in 2017 was made an honorary member of the World Psychiatric Association. I might add that Professor Hopwood has been a long-time supporter of the Mental Health Foundation and has always been supportive of our programs and efforts to ensure better mental health for all. Malcolm, it's my great pleasure again to welcome you here today, and we all look forward to what you're about to say. Thank you very much.
Yeah, thanks, Jim. And let me just quickly share my screen with everyone. And it is a great pleasure to join you. What I'm going to talk about today is really focused on the College Mood Disorder Guidelines, the College of Psychiatrists. And these were produced by that group of authors listed there, of which I'm just one and not the leader. And what I'm going to try and use these guidelines as is a way of sort of talking about how a psychiatrist thinks about treatment of mood disorders. I'll try not to be too technical in that and make sure we leave lots of time for Q&A, because really, in many ways, that's often the most useful bit of these things in my experience. But a great pleasure to join you. So just having a bit of trouble moving my slides, bear with me for 1 second. There we go. So these guidelines were published, in fact, earlier this year in the Australian New Zealand Journal of Psychiatry. And I'd really like to acknowledge my co-authors, led by Jin Marley from the University of Sydney. As always in writing guidelines, it's really very important that we're open and clear about any conflicts that might exist with funding from different bodies or companies or organisations. So I put them up there because I think it's really important to be open about that and to be clear about who you've worked with. To be crystal clear, none of them had any involvement at all in the production of the guidelines. So these guidelines actually cover both bipolar mood disorder, bipolar affective disorder, and unipolar major depression. And some of you have heard the terms depression and bipolar disorder and think, oh, it's kind of interesting they put them together. Why did they do that? Because I've heard that we use different treatments for each of those, right? Well, in essence, we're saying
Sorry, everyone. He'll be back soon.
oh, I think I might have frozen there for a moment. Am I back now?
Yes, you are.
Good. Apologies if I froze for a moment there. I'll blame the god of the internet, so I apologise. I was making the point that the guidelines cover both bipolar disorder and depression. And that's because as a group, we do think they're on a continuum. One of the questions I get asked about a lot is how do I go about making a diagnosis? And let me just go back. In making a diagnosis of either mania or depression, I rely on finding the key symptoms. And in the guidelines, we talk about the key symptoms falling into the domains of things that affect a person's activity, their cognition, their thinking, and their emotion. The emotion bit is what everyone immediately thinks about. Depression is about being sad, right? Whereas mania is about being euphoric and happy. And yes, that's true, but actually not everyone experiences those emotions. And just judging a diagnosis on emotion alone is tricky. So if, for example, I took the emotion of euphoria, for those of you who have the pleasure of barracking for Richmond, you would have experienced very transient euphoria after one of our many recent grand final wins. Is that enough to make a diagnosis of an illness? Well, absolutely not. At least I hope not. We'd look for a presence of other symptoms over an appropriate course of time. The activity symptoms in this diagram in green are the ones that often cause distress for others around the person. So, for example, the being up all night, overactive, working on projects in the person who's mildly manic can be what disturbs a family more than the person being euphoric. In terms of causing disability, the cognitive symptoms, so for example, down the bottom, difficulty concentrating and thinking, are actually some of the things that cause the most disability for people. Because if you can't concentrate, you can't work, you can't function in your other roles. It's incredibly disabling and actually causes more disability than many of the other symptoms. So in assessing a mood disorder well, covering that whole spectrum is really important. In the guidelines, we talk about the ACE model then, activity, cognition, and emotion. So a model of the clusters of symptoms we see in mood disorders. And this graph shows how they might vary for one given person. So an episode of a mood disorder might start out with not so many activity symptoms, but more disturbance in cognition, for example. Then as things get worse, activity gets severely affected. And then for that person, what they're left with at the end is mainly cognitive disturbance. For the next person, the pattern may be completely different. They may start with completely different symptoms. And so one of the things I'll often ask a person when I'm looking to prevent relapse is, can they identify which symptoms are the first to occur? Because hopefully, if we can pick that, then we can intervene before things get too bad. I'll also always ask them which symptoms are the hardest to get rid of, because we know persistent symptoms in whatever domain represent a much bigger risk for getting ill again, kind of not surprisingly in a way. As I mentioned, for individual patients, what symptoms are the main one at the onset and the offset of an episode varies. But for each person, there does tend to be a pattern where those symptoms are most likely to be the first symptom for each episode. Not always, but it can be a reliable and useful predictor that helps, as I say, to get early intervention going. Now, within the ACE model, we then look to define what's the current syndrome of mood disorder that the person's presenting with. So classically, we talk about depression with 2 weeks or more of things like lowered mood, loss of enjoyment and pleasure, sleep, appetite, and other disturbances that last every day, most of the day for those 2 weeks. Mania, classically, we talk about elevated mood for at least a few days, increased energy and decreased need for sleep, increased activity despite less sleep, and sometimes other more dramatic symptoms. But what we do know is that there are complicated states called mixed states, where some people, believe it or not, can have symptoms of depression and mania together at the same time or very close apart. That's a particular subset of people with bipolar disorder, and that diagnosis can be quite tricky. Within bipolar disorder, as you see in diagram C, there's also quite a range of how frequently people will have episodes. This is with or without treatment. Some people will have a high or a low, maybe once a year, maybe once every few years. Some people have multiple episodes a year. And if they have more than 4, we call this rapid cycling. And then there are some people who seem to have multiple episodes and are very rarely, unfortunately, stable in their mood, so-called ultra-rapid or ultradian cycling. I guess the main point I'm trying to get across here is that whilst classical bipolar disorder can present with clear-cut highs and clear-cut lows, it can sadly be messier as well. Now let's talk about treatment, because at the end of the day, that's the main thing that guidelines are there for. These guidelines are structured a little bit differently to some of the ones, if any of you have read them before, might have seen. The first thing they say in treating any mood disorder is our treatment goal is functional recovery. That is, getting back to doing things that are normal life, with all the variation in what constitutes a normal life, of course. That might sound fairly obvious, but many of our treatments have actually been measured more in terms of how good are they at treating symptoms. Well, symptoms are important, but it's actually being able to get on with life that we find people value the most out of their care. It varies from person to person. So we've placed functional recovery as the core goal. And ideally, that's complete functional recovery. We know that sadly, that's difficult to achieve for everyone, but it should definitely be our goal. We then divided treatment into a series of steps, if you like. Actions are those things that we're saying in these guidelines should be done or offered to everyone with a mood disorder. Choices are the things you'd add if the actions alone are either inadequate or ineffective. And then alternatives are when it's getting a bit tougher and things are not getting better. Clearly, at each level, we need to clearly review. Have we got the diagnosis right here? Are there other factors that are interfering with treatment being successful? There might be personal factors in a relationship, a job, finances, housing, physical illness, pain, any number of things. This is a change from previous guidelines for, say, depression, where they tended to say For mild depression, perhaps mild to moderate, we'd recommend psychological or psychotherapy treatment first. And for moderate to severe, we'd recommend medications first. We're actually saying now everyone should have psychological interventions offered. And I'll explain that a little more in a moment. So we're really saying biopsychosocial and lifestyle factors are critical in the management of mood disorders, both bipolar and major depression. Now, I mentioned lifestyle things in the actions. Let's just talk a little bit about are relevant. They may, on occasion, I think I may have frozen for a moment there again, so apologies. Here's a list of all the actions that we recommend in that lifestyle category. And let me just talk through them a little bit more. We hear a lot of discussion about things like diet and exercise and their potential utility in the treatment of depression in particular. And in the guidelines, we're saying, yes, they may have a role. That will vary in each case. And on occasions, they may be adequate without utilising things like antidepressant medications. But each case, we should look at all of these variables. So for many people with mood disorders, a loss of structure and routine is a critical part of how the illness affects them. For some people with mania, and even occasionally with depression, overactivity is a problem. And sometimes part of treatment is actually to say, wait, stop, slow down. Attention to sleep is critical in the management of mood disorders. Regular exercise and diet are important. And we've now got studies saying both of those may be, for at least some people, effective treatments in their own right. It's worth saying that's generally, as a treatment, fairly vigorous exercise for at least 30 minutes a day. But more gentle exercise can still be beneficial in protecting against the poor physical health consequences we see in people with mood disorders. We talk about that a lot in people with illnesses like schizophrenia, with increased rates of diabetes and heart disease. The same is true in people with mood disorders. So we need them to be physically well. Diet, and there's good evidence now about the potential impact of a Mediterranean diet on depression. The authors of those studies would say it may not be that the Mediterranean diet is specifically the right one. It's just as much about a good, balanced, healthy diet, which we know isn't necessarily given in our community. Amongst these compulsory actions then, we'd also talk about assessment of things like current levels of social support, risk, of cognition, so a person's capacity to think and make decisions for themselves, their level of education about the illness. We would particularly address substance misuse, because of course for some people, if they're currently drinking very heavily, for example, or abusing cannabis on a daily basis, that may actually be precipitating their mood disorder. And if we remove that, that may be treatment in its own right. And then we are recommending for all patients, psychological interventions be considered. And let me give you a little bit more detail about some of these. I've mentioned sleep hygiene. Now, giving people simple sleep hygiene advice when they're severely depressed or manic may be difficult for them to make changes, but it should still be trialled and it may still be reserved for something we can come back to later on. I've mentioned exercise and diet. I can't underemphasize the importance of taking a good look at alcohol and other substance misuse and other medications, prescribed or otherwise, that may alter mood. Because if we can intervene simply in these areas, that would be good at so many levels. Smoking rates are high in people with mood disorders, much in excess of the general population, and there clearly is a need for us to manage that if we're going to look after their physical health. I won't dwell on this group too much, but emphasising psychoeducation is interesting. It's always struck me as part of good care of people to talk about what you understand is wrong, what you think might be the factors leading to that, and we don't always know all of them, is the truth, and what we think about treatment, including future risk of relapse. We know from adherence data how good are people at sticking with treatment, be it therapy or medication, that most people seem to assume, once I'm a bit better, this isn't going to come back. And I'd actually say that represents a failure of our education to confront the difficult fact, it's not easy, that for a significant group of people, mood disorders are recurrent problems, and we need to put in place steps to decrease that risk. Now, what about this idea that everyone should be offered therapy? Wow, that's a big thing. As I said, historically, many, many guidelines said psychotherapy was better for mild to moderate. For severe, people couldn't benefit so much from therapy. But actually, more recent studies, that's probably only true for those people with a very severe mood disorder. So currently so severely depressed, they might have psychosis with depression or psychosis with mania, or simply can't attend. But that's actually a pretty small percentage of the overall group of people with mood disorders. So for most people with depression in particular, we strongly feel psychotherapy should be offered. It's not something everyone wants. I think we need to be real, but that doesn't mean they shouldn't be offered it. And we know most people would prefer to try that. I think it's also a recommendation that's based on, this is more accessible now than it was, a few years ago, really, through schemes like Better Access and greater availability of appropriately trained therapists. In talking about what type of therapy, which is usually the next question, we really wanted to emphasise a person-focused approach, and that actually the evidence says clear distinction as to which therapy is superior is arguable. There's a group of therapies, as I'll discuss in a minute, that have shown to be effective. And patient preference is relevant. Some people like talking in a particular way and not that way, and some don't. Here I'm emphasising patient preference, not necessarily therapist preference, and I think it's an important distinction. Of course, the nature of their presentation and the context of which you're treating things are relevant. Just a comment about digital delivery of therapy, which has been a very big and growing area now. And there is some data to suggest that internet-delivered CBT, cognitive behavioural therapy, where there is access to at least email guidance from a therapist, can be as effective as face-to-face therapy. Now, suddenly, every clinician in the room is kind of feeling a bit threatened and, oh gosh, what do I think about that? And as a group, we still wondered about that data. One of the challenges in doing those studies is you can't be blinded, can you, as to whether you're receiving face-to-face or internet-based therapy. I think it's pretty hard to camouflage what you're getting. So that data is still a bit difficult, but we do acknowledge digital delivery does have evidence to support it if done well. We may have thought most of those comments I just made would apply to depression, but they probably apply to bipolar disorder as well. That there is strong evidence now for a role for psychological interventions in bipolar disorder, particularly in the depressed phase and in maintenance to prevent relapse. Not surprisingly, I guess, less evidence of benefit when a person's manic, as you might expect. And the interventions that have the highest evidence base include CBT, which is true in depression as well, interpersonal social rhythm therapy, which is specific to bipolar disorder, and family-focused therapies we know have a good evidence base in bipolar disorder as well. Psychoeducation has a good body of evidence as a therapy for both depression and bipolar disorder. And the capital P there is to indicate really doing it properly with good education. In both bipolar disorder and depression, there isn't absolute evidence to differentiate which treatment is best. In the guidelines, we've made the comment that generally we go with those therapies where there's more frequently trained therapists available. And in the current climate in Australia, that probably would be things like CBT, perhaps IPT, maybe mindfulness for depressive relapse, and interpersonal therapy for bipolar disorder. But it's not necessarily a recommendation against other forms of therapy, if that makes sense. Also going to talk about antidepressants in a moment. If I've omitted that slide, I'll come back to it. So I was just introducing by saying we've got to talk about medications a little bit. The treatment of mania is probably more exclusively a medication-oriented exercise. And I think today the main point I want to say here is that it often involves the combination of a mood-stabilizing drug like lithium and one of the newer atypical antipsychotics. I'm not going to dwell on the detail because I don't think that's the point. But combined medication treatments can often be a bit alarming, I think. What does that mean that I need multiple medications? And the truth is that's about the challenge of effectively treating mania and sometimes bipolar disorder generally. I mentioned before these mixed states in bipolar disorder where you've got a bit of depression and a bit of mania going at the same time. I know it sounds a weird idea, but some of you may have seen people who have been affected by this. And if you ever meet people with bipolar disorder, it's funny, if you ever ask them, have you ever had it mixed up together? How many of them go, actually, yeah, I have, now that you mention it. It's really weird. And it's generally not good and not pleasant. That's why it's really important to pick up. We've probably focused more on these in recent years. And part of the skill here is really doing a good appraisal of a person's history with bipolar disorder. Because if you don't go over the history carefully, you can miss these episodes. So sometimes we get so focused on the current episode, we forget to take the history carefully to then make the best decisions about what treatment will we use now and how will that work going forward. Really, really important in good management of bipolar. Sounds pretty obvious, but when someone's floridly unwell, it's kind of easy to forget to try and take that time. Sometimes when someone's very unwell, of course, that may need other people to assist with that history. I mentioned these mixed states, and again, I apologise for quite a technical diagram about the medications we used in mixed states. I'm not going to go through the detail here because the truth is, because we're learning more about them, the absolute evidence for what's the most effective treatment here is a bit less clear. Some of you might be surprised to see ECT listed here. Do we ever use ECT still for mania or depression? And the answer is yes, we do. It's a treatment that still has the highest rate of response for severe depression. That's not getting better, and I mean severe, and can occasionally be useful in mania or mixed states in bipolar disorder that are not getting better. Without going into the detail of that graphic, I just want to emphasise ECT is actually a range of treatments, most of which look nothing like what you see in the films. Really important to emphasise. And we have newer versions like unilateral ultra-brief ECT, where memory effects are significantly less than they used to be. It's a treatment for a very small group of people. I want to emphasise that. This is about the treatment of bipolar depression. And it might surprise you to know it's actually one of the harder bits to treat. It tends to go for longer than mania and can grumble along and be very disabling. I'm not going to talk about the whole diagram, that would take too long, but some of you may notice AD stands for antidepressant. And you might be able to figure from that diagram that we seem to be saying when you've got bipolar disorder depression, we don't go straight to an antidepressant. And that's correct, if that's the kind of conclusion you reached. That's partly because of some concern that they might cause switching into a high, not just getting rid of depression, but switching you into a high, but also some evidence that, particularly once you've had bipolar disorder for a while, they don't seem to work as often as they do for non-bipolar depression. It's kind of going against what you'd think, because if it's called an antidepressant and you're depressed, you kind of think, why are you keeping that back from me? Well, it may be because in bipolar depression, they're not quite as good, but we will sometimes still use them, don't get me wrong. This is about the maintenance treatment of bipolar disorder, and I'm not going to go through this in detail. If any of you do want the detail, this session, of course, is being recorded, but also these guidelines are freely available through the college public-facing website, Your Health in Mind. And I encourage you to have a look if you like that level of detail. But again, I think the main point I want to suggest here is the combinations we use, or the individual medications, need to be based on a careful history, judging what's worked for this person, what side effects would worry them the most. Do we often end up with combinations? The answer is yes, we do. And do they need careful monitoring of a person's physical health? Yes, they do. They definitely do. And in my view, that's often done ideally in the context of a longer-term therapeutic relationship. Now, you might think, what's this diagram about? This diagram's meant to show something about mood fluctuations. Some would be aware that kind of terms like ups and downs in mood, fluctuating mood, even calling someone bipolar has kind of got into the everyday language a bit, hasn't it? You know, oh, so-and-so, they're a bit bipolar. Often when people say that, they're referring to someone who seems to go up and down, often very quickly, within a few minutes, maybe a few hours. Now, for some people, that can be actually their mood goes from being low to normal fairly quickly. For others, it can involve periods where they actually are briefly elated. Read the aforementioned Richmond supporter. But that's not bipolar disorder. While some people with bipolar disorder can have those micro fluctuations, they will inevitably have a history of protracted highs or lows lasting days and weeks. So if the history is only ever of these fluctuations, as best we can attain history, and sometimes it's difficult, then the diagnosis is probably not bipolar disorder. It may well be another diagnosis. So there are a range of other conditions that can cause fluctuations in mood. We see it in some people who are very anxious. We see it sometimes as part of particular personality styles. The treatment for those things would be very different. And that's why getting the diagnosis right is important. We don't want to expose people to the risk of treatments that are not going to be effective. What's the point of that? One other thing I want to highlight from the guidelines. I said earlier that unfortunately mood disorders can and are for many people recurring or difficult to treat problems. And that can actually be very demoralizing. You know, the experience of treatment not working is tough. Some people, as part of the way they're thinking and feeling when they're depressed, may even blame themselves or kind of lose hope and optimism. We think in terms of good practice, it's very important to be open and honest about this problem from the start and be talking to people about, hey, look, it mightn't be easy to find the right thing for you first go. We'd love to be able to choose the right treatment with certainty. It just doesn't work that way always. We've got some labels like treatment resistant or difficult to treat that have some use, but saying you're treatment resistant because you failed 2 treatments, when we can't know for sure which treatment's the right one for you as an individual, doesn't help you much as a person, makes it just make you feel bad. In the guidelines, we've talked about the idea of channeling response, that in every person's brain, because these things are ultimately brain problems, we need to find the right thing to unlock the blocked channel for you. We can't predict what will be the right key, if you like, or the right combination of keys for your lock, first off. So we need to keep working to find the right thing. And for one person, that might be a combination of an antidepressant SSRI like Prozac plus psychotherapy. For the next person, it might be a combination of medication or adding in a failure or a problem if the first thing hasn't worked. And apologies if I just missed a bit, but hopefully you've got the gist of that. We shouldn't see it as a problem if the first thing we tried doesn't work. That happens. Only about 40% of people fully recover with the first treatment for major depression. So it's not surprising if you need a second treatment. It's hard because that's extra time when you're unwell, but don't be too despondent and don't despair. There are lots of other options and we will find the right combination for you. I think that's a very important message.